of the skeletal system, we'll be looking at the appendicular skeleton, which will include both the upper and lower limbs, and also the girdles that connect it to the axial skeleton. Now, the main difference we see between the axial skeleton and the appendicular skeleton is its true function. For the axial skeleton, it primarily is used for protection, and then movement is going to be secondary, so naturally the skull and the face will protect the brain, as well as the spinal column for the spinal cord, and also the rib cage and part of the pelvic area, including the sacrum and the coccyx, is more so to protect a portion of the central organs, including the heart, the liver, the lungs, the stomach, as well as a few other of the gastrointestinal organs, and partially also protects the genitourinary as well. But for the appendicular skeleton, they are primarily used for movement and also for posture and stable positioning. There's 126 bones in the appendicular skeleton. As I mentioned in the last slide, it's going to include both the upper and lower limbs, as well as the girdles that are going to attach it to the axial skeleton. Here's a quick overview of individual bones. This is the same slide you have back from the axial skeleton as well. It'll give you a very basic overview, just the names of the bones and where they're located. However, for the individual landmarks, for depressions and the different types of protrusions, we'll go through each one of those particular bones as we go through the particular lecture. As the pectoral girdle, which is going to be comprised of two bones, you have the clavicle, otherwise known as the collarbone, on the anterior, and the scapula or the shoulder blade at the posterior. Here we look at the clavicle. It is an S-shaped bone. Here we see both a superior and inferior view. If you notice, the medial end is known as the sternal end, articulates with the manubrium of the sternum, the uppermost part of the sternum. The lateral end is going to attach to the acromion process of the scapula, which is a hook-like projection, which I'll show you in the next couple slides. Forms the acromioclavicular joint. The sternal end will form the sternoclavicular joint as well. Here we see the posterior portion of the shoulder girdle, known as the scapula or shoulder blade. This is a flat bone with many differing characteristics to it. Basically, the way we differentiate the anterior from the posterior is there's going to be known as a scapular spine. If you look on the posterior view on the bottom middle portion of the slide here, you see that scapular spine is continuous with the acromion. If you look at the lateral view, you can see how the acromion will actually project laterally and to the anterior as well as hooks up with the clavicle. Now, this bone is very important for a couple of different reasons. One, it's the major attachment point for all the rotator cuff muscles, which helps solidify the shoulder in its proper position. Because inherently, the way this particular bone is formed, if you look at the glenoid cavity, is where your humerus bone is going to attach to form the glenohumeral joint, also known as the shoulder. Now, because the glenoid cavity is a very shallow cup, the shoulder tends to be very mobile, but also tends to be very unstable as well, compared to another ball and socket joint, the hip, which I'll show you later on, which has a very deep cup and is very stable compared to the shoulder itself. Now, other things you'll see here, looking again at the posterior view, you're going to see the superior angle, you're going to see the superior border and the superior notch. You're going to have what's known as the supraspinous fossa found just above the scapula. And since you have a supraspinous, you'll find an infraspinous fossa just below that as well. You have a medial border and also the inferior angle. If you go further laterally, you see the lateral or the axillary border as it points toward the armpit area, also known as the axilla. And again, you can see the glenoid cavity, which is going to be lined with hyaline cartilage. If you look at the anterior view on the upper right-hand corner, you see the acromion again hooking towards the anterior. You can see the superior angle, border, and notch from the anterior side. You also see the coracoid process, which is going to be found projecting to the anterior, and also lateral. This will be a major attachment point for a few muscles in particular, the coracobrachialis and one aspect of the biceps brachii. You have a subscapular fossa, which is going to be the resting point for one particular part of the rotator cuff muscles. It's known as subscapular because it's going to be sandwiched between the scapula itself and the rib cage. The scapula hangs on the rib cage very simply by an accessory of different muscles, so it forms almost a pseudo joint, not a true joint because there's no synovial capsule there, but there's a pseudo joint there where occasionally the shoulder the shoulder blade can get locked onto the rib cage and cause some disruption with how the shoulder works in and of itself. Moving distally from the pectoral girdle of the scapula and clavicle, we find the humerus or the arm bone. This will create the brachium of the upper extremity, which is the upper portion of the arm. It will articulate with the scapula proximally in the glenoid fossa, and it will articulate distally with the radius and the ulna, which will form a two-bone portion of the antebrachium, also known as the forearm. Here we find a right humerus as it attaches to the right shoulder blade and the clavicle. You see that it has a head and a neck, and we have two different necks here on the humerus. You see the head will be aligned with cartilage as it articulates with the glenoid fossa of the scapula. You'll find both an anatomical neck and also a surgical neck. The difference being the anatomical neck is the true neck of the humerus where the head will rest on top of the neck, whereas the surgical neck is the area where it's most often fractured due to injury, whether it be from a lateral injury or also from an impact injury with arm stuck straight out. Also very close to the head, if you look more anterior and laterally, you see two tubercles, a greater and lesser tubercle. This actually has what's known as transverse ligament that runs across it to form the intertubercular sulcus or groove. This is where your biceps tendon will lay. We'll get more into that. We'll get into different muscles and muscle attachments. If you go down towards the middle of the diaphysis, you notice there's a deltoid tuberosity. This is a little bit of a projection where the tendon of the deltoid muscle will rest. With that muscle contracts, it'll tug on the area deltoid tuberosity. So over time, that builds up a little bump for the actual tendon to attach to. Further down in the distal portion, you find the rest of the body or the shaft. As you travel down towards the distal end of the humerus, you're going to notice two different things. You'll notice first there's a hyaline line cartilage partition there. There's going to form a rounded portion laterally called the capitulum, and also the trochlea. This is where you're going to have both the ulna and the radius going to fit together to form the elbow. It also has two fossas, a radial fossa and a coronoid fossa. This is going to articulate with both the radius and the ulna. These are going to be little depressions here to allow certain protrusions on the radius and ulna to fit in neatly, and this also will help limit a certain amount of motion in the elbow itself. You also have two things known as epicondyles. These are going to raise projections off of condyles, although the condyles are not called that here. That's going to be the capitulum and the trochlea. Those are the rounded partitions. Both your lateral epicondyle and the medial epicondyle are very simply going to be attachment points for ligaments and tendons to basically hold the brachium to the radius and the ulna when the elbow moves back and forth in flexion extension, and with a little bit of lateral motion there as well. Looking at the posterior view, you can see the most lateral portion of the greater tubercle. You see the rest of both the anatomical and the surgical neck. You'll find the radial groove. This is where the radial nerve will pass through. And also you can see what's going to be known as the olecranon fossa. This is where the actual olecranon, or the actual elbow itself, will fit into, and this helps prevent excessive motion or too much hyperextension in the elbows. Some of us have a little more hyperextension than others, which we'll get into the joints lab. We'll simply test that and see who has more hypermobility versus someone else. So the ulna and radius will make up the antebrachium, or the lower portion of the upper extremity, also known as the forearm. You're going to find both the olecranon and the coronoid process at the end of the ulna. This is going to be the olecranon in the posterior, coronoid process in the anterior, from the trochlear notch, which will wrap around the trochlear humerus, making up the elbow joint. So that's the true elbow joint there. There's a second joint there as well, where the radius is going to articulate with the head of the capitulum of the humerus. If you notice on the capitulum in particular, it's going to be rounded. It allows the ulna and the radius to rotate around that particular area, and allows the forearm to rotate, basically spin the hand in different positions, as we know as supination and pronation. So it's important to know that we have any kind of rotation at the forearm. It's not happening at the wrist. It's actually happening back at the elbow between the radius, the ulna, and the humerus. So you can see the elbow joint and also a portion of the wrist joint as well. So again, looking at the humerus, we see on the left side the anterior view. We can see the capitulum on the lateral end, and always note that the radius in the anatomical position will always be on the thumb side or the lateral position for the upper extremity. You're going to find the head of the radius and the neck of the radius there. You're going to find both a radial and also an ulnar tuberosity on the differing radius and ulna. So when you go to bend the elbow or flex the elbow towards the trunk of the body, the radial tuberosity will fit itself right into the radial fossa, whereas the ulnar tuberosity and the coronoid process will approximate towards the coronoid fossa and will basically stop you from flexing the elbow too much. So it limits that particular motion on the anterior side. On the posterior side, looking at the right side of the diagram here, we see the olecranon fossa. You see olecranon when the elbow is fully extended into a straightened out position. It holds itself in the olecranon fossa there as well. So when you're looking at flexion and extension of the elbow, it happens between the humerus and the ulna. If you're looking at any kind of rotation of the forearm, looking at the head and neck of the radius is going to spin on the capitulum, and basically the ulnar and radius kind of roll over each other, which we'll demonstrate when we get into the articulations lab. Now, there's a major ligament that actually attaches the ulna and radius together, known as interosseous membrane. We have one other one found in the lower extremity, which I'll describe to you later on in this chapter. So that helps bind the two lower portions of the antebrachium. And if you look a little further down, you can see two processes on either side of the ulnus and the ulna and the radius as it articulates with the wrist, known as the styloid process of the radius or the styloid process of the ulna. Very similar to the epicondyles found on the humerus, these are going to be ligamentous and tendon attachments to help maintain position of the wrist and also maintain muscle attachments to move the wrist. Close-up view of the actual elbow joint. So very simply, if you look at the top portion here, which is shown to be the median view of the relation to the humerus, so we're looking at the medial epicondyle, the humerus, and the coronoid fossa. You see the coronoid process on the ulna. As it slides on the trochlea, it'll approximate and actually lay itself into the coronoid fossa of the humerus. On the radial side, you can see there, you can see the capitulum of the humerus and the head of the radius. That will allow the upper forearm to spin back and forth on the capitulum there. So when the hand is in the true anatomical position, it's called the supinated position. So the palm is face up or facing to the anterior. The ulnar radius will line up as radius being lateral, ulnar will be medial. When you flip the hand over into the pronation position, very simply, the radius will basically spin its head on the capitulum and roll over onto the ulna. Now it can do this because it has a special little notch on the proximal end of the ulna. So if you look at the lower left-hand corner here, there's a lateral view of the proximal end of the ulna. You see the olecranon on the posterior and the trochlear notch, as well as the coronoid process and the radial notch, are all lined with hyaline cartilage. So very simply, the trochlear notch will fit neatly into the trochlea itself and allow the coronoid process to fit into the coronoid fossa of the humerus. And the little radial notch just on the lateral end there allows the radial head to spin itself over onto the ulna when it goes from the supinated position to the pronated position. And finally, look at the lower right-hand corner. This is going to be the distal end of the radius of the ulna. So you can see again hyaline cartilage lying on the head of the ulna as well as the head of the radius as well. You can see the articulation with the scaphoid. This will be one of your wrist bones. You can find both the styloid process for the radius and also the ulna. Now keep in mind, when we do any kind of quiz or any kind of exam, these diagrams are fair game. So orient yourself simply to all different kinds of views of each individual bones. This is why the labs and also using Wire Plus to be able to manipulate some of the bones and look at it with different angles can be very, very important to learning these particular articulations and also the different processes and also crests and depressions found within each bone. Moving distally from the radius and ulna, we find all of the carpal or the wrist bones. So these are 8 small cube-like bones that are connected to each other by different types of ligaments. They form 2 rows. You have a proximal and a distal row. The proximal row is made up of what's known as the scaphoid, the lunate, triquetrum, and the pisiform. This will also articulate with the distal row known as the trapezium, the trapezoid, the capitate, and the hamate. The distal row will actually articulate with the hand bones known as the metacarpals. Now, learning the wrist bones can be tricky, especially where they're oriented both in proximal and distal rows. So again, in the proximal row, we have the scaphoid, lunate, triquetrum, and pisiform. In the distal row, the trapezium, the trapezoid, the capitate, and the hamate. The textbook gives you a mnemonic, and I also threw in a mnemonic I used to use back in school as well. Use whichever one works best for you. But very simply, remember either stop letting those people touch the cadaver's hand, or no, some losers try positions that they can't handle. I personally like mine because it's almost 2 sentences, 1 or 2 phrases, 1. The first 4 words gives you the proximal row. The last word gives you the distal row. Either one works fine. Whichever one works better for you, want to come up with your own, that's fine as well. So very similar, the way I remember it, as some losers try positions, the scaphoid, lunate, triquetrum, and the pisiform are in the proximal row. In the distal row that they can't handle, the way I always remember it very simply is the trapezium, the trapezoid, because they're both trapped together. The trapezium is going to be first in the alphabet, followed by the trapezoid, then the capitate, and the hamate. So when we read these, we're reading this off as if we're going from the lateral to the medial and the anatomical position. So again, some losers try position that they can't handle: scaphoid, lunate, triquetrum, pisiform, followed by trapezium, trapezoid, capitate, and hamate. So we look at the hand bones. It's made up of 5 metacarpals. It's going to be numbered in the Roman numerals 1 through 5, starting with the thumb first. So again, we're reading from the lateral to the medial. So if you want in more layman's terms, the thumb would be 1, your index finger would be 2, the middle finger would be 3, ring finger 4, and the pinky would be 5. So the 5 metacarpals make up the hand bones. These will articulate with the distal end of the carpal bones, and then they'll actually attached to the proximal ends of the phalanges. Now, for the phalanges, we have 14 phalanges on each hand. Very simply, we have 3 on each of the fingers and 1 on the thumb. Very simply, there's a little bit of semantics there. Some people feel that the thumb is also a finger, some people don't, but they're all phalanges. So very simply, we're talking about fingers in this class. We're only talking about the 4 fingers, the index, the middle, the ring, and the pinky. So Roman numerals 2, 3, 4, 5 phalanges. The first phalange is only going to be the thumb itself. Now, the difference between the thumb and the 4 fingers is the four fingers will each have 3 phalanges, a proximal, a middle, and a distal. The thumb only has a proximal and a distal. There is no middle on the thumb in particular. So you can see why we use mnemonic for the carpal bones, because you look at both the anterior and posterior view, it looks like a little bit of a mess. Unfortunately, if we get into the lab or look through Wiley Plus, you can look at these a little more closely and kind of get a better idea of how things are oriented. Unfortunately, though, on this particular slide, it's a little tough to see. In particular, there's one bone of the wrist known as the pisiform. If you look at the proximal row, this one's formed a little bit differently. So if you look at the carpals, especially on the distal end of the radius here on the lateral side, the scaphoid is going to start the articulation of a radius and start the actual thumb itself. When you start moving more towards the to the medial position, you're going to find the lunate, and then finally the triquetrum. And if you were to look at a real bone of the a real wrist bone, the pisiform is going to sit on top of the triquetrum. So the pisiform is actually sitting on top of the triquetrum, facing us to the anterior. So it forms almost like a C shape for the proximal carpals. Now, as far as the distal carpals, this one actually does a pretty good job of showing all the carpals in the distal row: the trapezium, trapezoid, the cavity, and the hamate. If you look at the hamate on the anterior view, it's a little tough to see here, but I'll show you a different slide. It has a little hook on it. It's actually going to be very important for a particular type of tunnel, not the carpal tunnel, but a different one we'll talk about in just a few seconds here. And you can also see in the Roman numerals, you can see them numbered 1 through 5. Again, 1 being the thumb, 2 index, 3 middle, 4 ring, and 5 as the pinky. Now, these are going to have hyaline cartilage on either end, both the proximal and distal ends. If you notice, the fingers themselves, the actual metacarpals and the phalanges, are all long bones. They're small, they're still long bones in the same situation as the humerus and also the ulna and the radius. So they're going to be hyaline cartilage lined on both the proximal and distal ends. So you can see here as well, there's going to be 2 phalanges on the thumb, otherwise known as the pollex. That's something to remember later on, especially if you start naming different muscles. But the thumb itself is going to be named as the pollex. You can see the other, both the proximal, middle, and distal phalanges on each of the other 4 fingers. Now, this particular slide is not in the appendicular skeleton chapter. It's actually being found more so when we get into the muscle chapter. But I feel it's a good idea to kind of throw this in here so you kind of get an idea of how the carpal tunnel is going to be shaped and how the orientation of the bones found in the wrist also dictates how different problems with any kind of carpal tunnel issues can occur. So very simply, we're looking at a transverse section of the right wrist. So first, let's look at the bones. So again, look at the pisiform more towards the anterior as it sits on top of the triquetrum. You're going to find that the posterior end as well as the medial and lateral ends of the carpal tunnel, which is going to be comprised of those particular tendons of the flexor digitorum superficialis, the flexor digitorum profundus, and the tendon of the flexor pollicis longus. Don't worry about those particular tendons as of yet, but you notice sandwiched up in the upper right-hand portion of the carpal tunnel, there's your median nerve. The median nerve there is the one that's usually implicated in any kind of carpal tunnel issues. Notice how many structures that are around that. You've got what's known as the retinaculum, which basically kind of knits everything all together very tightly in a particular spot. So you can imagine that that space does not offer a lot more room for any additional scar tissue or additional fluid in a particular area. So any kind of pressure can disrupt the carpal tunnel very easily. If you look just anterior to that, you can see also the ulnar artery nerve. If you look at lateral and posterior to the carpal tunnel, you see the radial artery nerve there as well. So you have some small muscles around there forming the thenar and the hypothenar muscles. Those are going to form the pads on the inner portion of your hand. So very simply, you can see that any kind of malposition of any one of the bones in the carpal tunnel can push upon either the tendons or cause pressure on that particular nerve there as well. So very simply, you can imagine that any kind of people that do any kind of repetitive stress at work, say any kind of typing, or if they throw balls, for a living, can put a lot of pressure on that particular wrist. People that drive a lot, people do any kind of manual construction, or use any kind of jackhammers, you can kind of see that any kind of repetitive stress can really cause some disruption on not only the median nerve, but also problems into the tendons there as well for the carpal tunnel. Now compare that to what's known as the ulnar tunnel, or Guyon's canal. This one very simply has the ulnar nerve. You may know this one better by the funny bone nerve. This is going to run just underneath the ulna as it wraps around, and it's going to actually go through both the hamate bone and also the pisiform. This is going to be covered by a ligament in that particular spot. The name of the ligament is not very important right now, but the ulnar nerve very simply passes through that particular spot. So our first question of the lecture is going to tackle the carpal tunnel and the tunnel of Guyon. Very simply, knowing how both the carpal and ulnar tunnels are formed, how might disruption occur, and what kind of symptoms would you expect into the hand and to the fingers? Also, which nerve do you think is more susceptible to disruption and why? So let's talk about this from the wrist perspective in particular. So we're going to talk about what structures are in the carpal tunnel, also what nerve is being disrupted. And even though you may not be aware of this as of yet, I'll talk briefly about how the median nerve works, how the ulnar nerve works there as well. Although most of you have probably injured the funny bone nerve, the ulnar nerve, as a kid a long time ago. Unfortunately, some of you may also have problems with the carpal tunnel even now as college students. So true carpal tunnel syndrome is compression of the median nerve. Now, even though people may come in and see someone like myself, or see other physical therapists, or see other massage therapists, other physicians, even though they have wrist pain, does not mean they have true carpal tunnel syndrome. True carpal tunnel syndrome is going to be compression of the median nerve. Now, the median nerve is going to control the majority of the muscles to help flex the fingers together to form a fist, or also to flex the wrist means moving more towards the anterior. It also can innervate or cause some sensation issues in the pollex, in the thumb, or also in phalanges 2 and 3. Usually occurs because of repetitive stress or hypertrophy of flexor tendons. And what we mean by hypertrophy, it could be repetitive stress, or it could be an injury where they tend to swell, which some of you may be very familiar with, known as tendinitis. You can also have repetitive stress of the flexor retinaculum, where very simply the covering, the ligaments covering becomes either torn or becomes inflamed, or sometimes both. So that basically will compress on the median nerve. Or it could be just simply flexion extension injuries to the wrist. Oftentimes we see this with car accidents. We might see these with falls from a bike there as well, where either the wrist is flexed in the anterior position or extended back in the posterior position, which a lot of times can cause a lot of disruption to the carpal tunnel. So very simply, the carpal tunnel has a lot of different structures here that can disrupt the median nerve, which can cause either weakness in the hand, it can cause problems with sensation, with problems with gross and fine motor control as well. More often times than not, this can be fixed through physical therapy or through chiropractic or even massage therapy. In very few cases, it may need some type of surgical intervention to either do some debridement, take away some of the scar tissue from the tendinitis, or oftentimes we have to cut the flexor retinaculum and reattach it just to open up the carpal tunnel area to get more room to move. Now, conversely, ulnar turn syndrome actually occurs less at the carpal area, because very simply the ulnar nerve only passes between the hamate and the pisiform underneath that particular ligament, so there's not as much mechanical stress at that particular area. It's actually more so due to malformation of the hamate. So for most people who have problems with the ulnar nerve in particular, this is known as the funny bone nerve, this is going to innervate the medial two fingers of the hand, which is going to include phalanges 4 and 5. This also, when it gets disrupted, most of you have structured funny bone nerve before, can cause tingling in those areas and sometimes weakness. Those muscles also help with some flexion maneuvers of the fingers and also the wrist. Also as well some deviation, which we'll get into later on in the muscle chapters. So usually for the ulnar nerve, in the particular, in the wrist, we see more problems with either repetitive stress of the wrist itself or possibly malformation of the hamate bone, but it's more susceptible at the proximal radial ulnar joint, which again will be at the medial portion of the elbow, just underneath the, or just more posterior to the medial epicondyle of the humerus. It's more susceptible to strikes there and disruption there as well. Different types of fractures we see with the hand and the wrist is known as a boxer's fracture. Very simply, you see this with boxers who strike kind of incorrectly a little bit. Those of you who've done any kind of martial arts or any kind of boxer training, you're taught to actually strike with the distal ends of the second and third metacarpals. So if you look at the hand here, you're not striking with the thumb, you're striking with the most proximal knuckle of the middle finger as well as the index finger. If you're, let's say you're wildly off or inexperienced or even drunk, a lot of times people will strike with the fourth and fifth phalanges, which tend to be a little bit more movable. If you notice, if you actually grab onto the base of the pinky and kind of move it back and forth into anterior and posterior position, it moves very freely. If you take the index finger, it doesn't move quite as much there. It is unofficially known as a Varum fracture, where a lot of times you'll see this, again, when people are usually drunk, and usually they'll either hit someone very poorly and possibly fracture either one of the metacarpals or a phalange, or they may strike immovable objects, say like a wall, concrete wall, or even plaster. A lot of times can cause the kind of fractures there as well. So in this case, it's a fracture of the neck of the fifth metacarpal bone. Kienbock's disease is a little bit different. This is an X-ray of a wrist where, very simply, the calcium or the bone actually starts to wear away. So this happens from what's called avascular necrosis of the lunate bone. So this only happens for the lunate bone for Kienbock's disease. You need both an X-ray and MRI is needed to diagnose. Very simply, the blood supply gets cut off somehow, usually again from either some type of stress, some type of fracture. It could be a repetitive stress kind of thing there as well. So very simply what happens is the bone starts to necrose or starts to die off. So very simply then the soft tissues around it starts to harden and calcify as well. So oftentimes it'll actually calcify and lose its synovial joint and not be able to slide particularly well with the other carpal bones or even into the radius as well. And will eventually calcify and actually lock up the wrist. Next, we'll move on to the pelvic or the hip girdle. Very simply, the hip girdle is going to be made up of two bones called hip bones, also known as the os coxa or the coxal bones, that's going to articulate with the sacrum posteriorly. Now, this is going to be a little bit different than what most people assume is going to be the hip. So the true hip is going to be the pelvic girdle itself, whereas the hip bone, or what most people think of the hip bone, is actually going to be your femur. We'll go into that a little more so when we look at the attachment of the os coxa to the femur when we look at the ball and socket joint of the hip. Now, each hip bone or each os coxa is made up of three distinct bones: the ilium, the ischium, and the pubis, or also known as the pubic bone. Now, these will also articulate in the front anteriorly at the pubic bones with the pubic symphysis. This is going to be a fibrocartilage disc, very similar to the disc found in the vertebral column, except this one sits more on the vertical instead of the horizontal. So it does not have the same kind of stresses, so you don't see any kind of herniations usually with the fibrocartilage of the pubic symphysis. Eventually, these bones eventually start out as three individual bones. They eventually fuse by the time you're 23. So this has quite a few different features to it. So if you look very simply first at the lateral view on the left here, so just looking at the three different distinct bones here. The superior and the largest part of the os coxa is going to be known as the ilium. The most posterior is going to be the ischium. You see in a very light red or pink. And then anterior is going to be pubic bone, which is going to be found more in blue and gray. Now, one thing I want to point out here is you notice there's a little cup there that's formed. This is known as the acetabulum. It's going to have equal parts of the ilium, ischium, and the pubis. All three will have some part in making up the acetabulum. Now, the lateral view on the right-hand side is a lot more detailed. So there's a lot of partitions here, a lot of crests, a lot of depressions, as well as projections I want you to be aware of. So if you look more so on the ilium first, let's take it piece by piece. You're going to find what's known as the gluteal lines, the anterior, inferior, posterior. This is very important for the attachments of the gluteus max, the medius and the minimus, as well as a few others. The wing-like projection that you see just superior on the ilium here is known as the ala, very similar to the sacral iliac we saw on the sacrum as well. And just atop that is going to be known as the iliac crest. Now, the iliac crest is important for a few reasons. One, iliac crest is a major attachment point for other muscles, including parts of the abs, as well as the iliopsoas muscles and also the quadratus lumborum. We'll get into those later on in the muscle chapter. But also the iliac crest is the main area that if you go into a bone graft, they usually would take it off the iliac crest. Some other features you'll see here, and these are mostly attachment points for muscles and or ligaments. If you go on the anterior, which is going to be on the far right-hand side here, you have what's known as the anterior superior iliac spine. We shorten that to ASIS. And of course, if you have a superior, you're going to have an inferior there as well. So you have the anterior inferior iliac spine there as well. So you move to the posterior, you're going to find the posterior superior iliac spine. Of course, just underneath that is the posterior inferior iliac spine. Next, you'll see the body of the ilium just over top of the acetabulum, which will be the cup where the actual head of the femur will rest. Before we get away from the ilium, let's also look at the greater sciatic notch. So greater sciatic notch is where your sciatic nerve, as well as other blood vessels and other portions of the nerve will basically pass through as well. Look at the ischium, which is going to be the pinkish bone on the most inferior side here. You find the body there and ischial spine. You're going to find the lesser sciatic notch, which will be just a smaller partition than the greater sciatic notch. You find the ischial tuberosity just almost to the bottom portion of the ischium. The ischial tuberosity is important for a few reasons. One, it's a major attachment point for your hamstrings, and also this is nicknamed the sit bone. So when you go to sit down, you're really sitting on your ischial tuberosities. The ramus of the ischium, very similar to the ramus of the mandible, is going to connect the body of the ischium to the next bone, which is known as the pubis here as well. Now, the pubis is going to be the most anterior bone that we're going to have on the os coxa. You can see both the superior and also the inferior ramus of the pubis. You find the pubic tubercle, which will also be an attachment point for the abdominals. And if you notice too that the pubis as well as the ischium is going to form a little hole there called the obturator foramen. Very similar to the foramen magnus, it's going to be a large opening. The only difference though is the obturator foramen is actually be covered by the obturator ligament with a very small partition there to allow blood vessels to pass through. Now the head of the femur, also known as the thigh bone. So again, for the femur in this course is not the actual hip. The hip is actually going to be the os coxa, and the femur is also going to be known as the thigh bone. This is going to fit inside the acetabulum of the hip, and is also going to be another ball and socket joint. But in this case, because the socket is a little more deep, and also we're going to see when we get into the joints themselves, the hip is actually fairly well surrounded by a number of strong ligaments. So this ball and socket joint is not going to be quite as mobile as the shoulder joint, but it will be a little more inherently stable. It's more help kind of keep it all in one particular spot. But again, as to help remember, it's going to be composed of all three parts of the bones that make up the hip. So now let's look at how the os coxa will articulate with the sacrum. So there's a nice little anterior superior view of the pelvic girdle. So the anatomical landmarks we're going to focus on here very simply are going to be the sacral promontory, which is going to be the most anterior portion of the sacrum itself. Now this is going to be continuous with the pelvic brim. Now the pelvic brim is going to be arranged from the sacrum as it goes laterally towards the hip bone. It's going to follow in towards the pubic bone and cross over the pubic symphysis. It's going to be formed by the sacral promontory, the arcuate line, and the pectineal line and the pubic symphysis. This is going to form what's known as the pelvic brim. Now this is important for the main reason, especially for women in particular, where you're going to be birthing the baby. It's going to be that pelvic brim is going to determine whether you have enough room for the baby's head to pass through. This also helps us differentiate between what's known as the false and the true pelvis. Now the true and the false pelvis very simply will give us an idea of exactly how much room is needed for the baby to pass through. It also gives us a good idea of where the anatomical landmarks will determine where certain types of organs are going to lay. So very simply, anything that's going to be above or superior to the pelvic brim is going to be known as the false pelvis. Anything that's going to be inferior to the pelvic brim is going to be known as the true pelvis. Now the true pelvis in particular is more important for the birthing of the baby in particular, as it also leads into how well it's going to pass through the pelvic outlet, which you can look on the lower right-hand corner of the sagittal section of the true and false pelvis. Very simply, you can see that the full plane of pelvic brim, as it goes in the true pelvis, also has to pass through the coccyx as it passes just posterior to the pubic symphysis there as well. Now, the one good thing about when women are giving birth, there's a hormone known as relaxin that kicks in. It actually allows some expansion of the ligaments and all the tendon structures to allow the pelvic brim to expand up to a certain point. But we have seen, especially with the number of cesarean sections that are being done over the last 10, 20 years, we've noticed that babies' heads have gotten bigger, but unfortunately women's pelvises have not gotten bigger along the same rate. So we're seeing a lot more cesarean sections over the last 10 to 20 years. So here's a nice little shaded view of both the false and the true pelvis. So again, remember, looking at the pelvic brim, it's going to be formed from the sacral promontory of the sacrum, all through the arcuate and the pectineal lines to the pubic symphysis. Anything that's going to be superior of that brim is going to be the false pelvis, shown in pink here. And of course, anything below or inferior to the pelvic brim is shown as the true pelvis, as blue on the right-hand side. And we can identify a male and female pelvis by a number of different characteristics. Number one, the male pelvis tend to be a little larger and heavier on the average versus the female. The other difference that we're going to notice for the female versus male is the female, we're generally going to have differences that basically aid with either pregnancy and or childbirth. In general, the female pelvis is going to be wider and also shallower than that of the male. Now the chart here and also on the next slide are a great representation of the differences between the male and female pelvis. So again, in general, the female is going to be lighter and thinner than the male, but also going to show a shallow, false or greater pelvis. The pelvic brim or inlet is going to be more wide and more oval, whereas more so on the men is going to be more heart-shaped. The acetabulum, that's going to be the cup for where the femur head is going to rest, is usually smaller and going to face more anterior, more so in the female, whereas the male will tend to be larger and face laterally. This also has something to do too with when we talk about the joints of how the femur is going to orient with the rest of the lower extremity and how different types of knee problems will occur under female versus male runners and other athletes. We'll get to that a little later on. The posterior foramen is going to be mostly oval shaped for the female and round for the male. The pubic arch is going to be greater than 90 degrees or be known as obtuse, whereas the male is going to be less than 90 degrees or more of an acute angle. You kind of see the triangles there on the pubic arch. So very similar to the pubic arch is going to be between the two ischium as they form with the pubic symphysis is going to be greater or obtuse on the female and then lesser than 90 degrees or acute on the male. Iliac crest tends to be a little less curved on the female but more so on the male. The ilium will be a little more vertical on the male, less so on the female. The sacral notch will actually change quite a bit. In the next slide, you'll see more of a lateral shot. You're going to see a very wide greater sacral notch on the female and very narrow for the men. And oftentimes you might see it looks like almost like an inverted V. The coccyx tends to be more movable and also more curved anterior on the female, whereas less movable so on the male. This also has something to do too when people have any kind of coccygeal injuries. I generally see more female, but whether that's because of more movable coccyx or not, I'm not entirely sure. The sacrum also tends to differ a little bit on the male versus female. It tends to be a little bit shorter and wider on the female, a little less curved anteriorly, again to allow more so for both the pelvic brim and also the pelvic outlet to be a little bit more malleable to allow the baby's head to drop. Whereas the men tend to have more of a longer, narrower sacrum, also a little more of a curve anteriorly because they simply don't need much of a pelvic brim or a pelvic outlet for obvious reasons. So here's a nice little comparison of the female and male pelvis. You see on the right lateral views on the upper portion here. So you see on the left, you see a greater sciatic notch on the female versus the male. You see a very slight differentiation on the angles of the coccyx, the female versus male. Very simply, it's going to be a little shorter. Will also bend a little more to the anterior, be more flexible on the female. And then again, looking at an inferior view of the male and female, look at the pelvic outlet. So you can kind of see that it's going to be a little bit wider on the female versus more the anterior posterior position. So from medial to lateral, you have more of a pelvic outlet versus anterior posterior. Whereas on the male side, it tends to be almost uniform, a little closer together. More so anterior posterior and the lateral and the medial tend to be somewhat closer together there versus the female. Next we have the femur, also known as the thigh bone. This is going to be the longest, heaviest, strongest bone in the body. Those of you that will be in lab, you'll have to pick one of these up and get an idea of how strong this bone actually is. The head is going to insert into the hip joint, right into the acetabulum of the hip bone, and we get to the actual joint chapters. You'll see this will be encased in different ligaments. That's going to be the proximal end. The distal end of the femur is going to articulate with the tibia, also known as your shin bone, also the patella or your kneecap. The femur will not articulate with the next bone I'm going to show you, known as the fibula. So again, the femur is going to articulate with the os coxa proximally, and distally it's going to articulate with the tibia and also the patella. So here you can see that the femur attaches nicely into the acetabulum of the os coxa. So you can see the head, again, lined with hyaline cartilage, and anytime you have a head, usually you have a neck as well. So you can find the neck here is going to be found projecting to the lateral, and also for some portions anterior and also inferior there as well. Now this particular neck is both the anatomical and the surgical neck. So unfortunately the same area where it thins out is also the area where it oftentimes will fracture due to injury or sometimes osteopenia or even osteoporosis. Now this also has two distinct features not found in any other bone, known as the trochanters. You have both the greater and lesser trochanters. The greater trochanter in particular is going to be attachment for the glute medius as well as the iliotibial band. Those are your runners, you know exactly what muscle that we're talking about there. So that tends to be a very strong attachment point for muscles and ligaments. You're also going to have the intertrochanteric line, which is going to be continuous from the anterior to the posterior. If you go on the left side of the anterior view, you see a very long body of the diaphysis of the femur, And then you're going to see the patella resting just anterior to the femur. You have what's known as the adductor tubercle. So the tubercle there is going to be a little bony projection there for attachment for the adductor muscles. These are muscles that are going to draw the knees together. If you look on the anterior side, you can see what's known as the lateral and medial epicondyles. These are roughened portions for muscle and muscle tendon ligaments attachments. And then just distal to that, you can see the tibia, which we'll get into just a few moments. A little further on the little inferior and also lateral, you can see the fibula. As you can see, it only connects to the tibia. It does not articulate with the femur. Now, looking at the posterior view, you can see again the greater trochanter there as well. You can find the lesser trochanter and the intertrochanteric line, and also the crest. Again, these are going to be tendon, muscle, as well as ligaments attachments. You have the gluteal tuberosity as well as the linea aspera. The linea aspera, aside from the ischial tuberosity, the major attachment point for the other head of the hamstrings. Now, anytime you have epicondyles, you're going to have condyles there as well. In this case, the condyles of the femur, you see the hyaline cartilage and next round projections there, are going to project posteriorly. So you have both a medial and lateral epicondyle, and found between is known as intercondylar fossa. This will be very important for the cruciate ligaments in particular, but just atop, or I should say more superior and also superficial to the condyles, you find the epicondyles, both medial and lateral. Here you see the kneecap, also known as the patella. This is going to be a triangular bone that's going to develop in the quadriceps tendon. This is known as a sesamoid bone because it's going to be enveloped in the quadriceps tendon. However, it does articulate with the femur. So if you look at the anterior view, notice how the patella is very rough, but the posterior view here is going to show two different facets here, both the medial and also lateral facets for the lateral medial epicondyles. Lateral medial femoral condyles as they slide back and forth. Now, oftentimes, and we'll get into this later on, a lot of times this kneecap can get disrupted and slide either lateral to medial or medial to lateral, and slide out of a particular groove where these particular facets will now also rub against different parts of the cartilage on the femur itself. Now, lower leg also has a two-bone system here known as the tibia and the fibula. The tibia is commonly known as the shin bone. The fibula is going to be the more lateral of the two. The way you simply remember this is if you say fibula, fibula is lateral. The tibia's proximal end is going to articulate with the femur, and the distal end is going to articulate with the talus, which is known as your ankle bone. The tibial tuberosity is going to be the most anterior portion, a very high crest. On the anterior surface is going to be the point attachment for the patellar ligament. It's also going to be attachment as well for the patellar tendon for the quadriceps. Here's the orientation of the lower extremity. Of course, the femur is going to be the proximal articulation point with the tibia. If you notice here on the anterior portion of the tibia, there's the tibial tuberosity. It's going to have its own condyles, both the lateral and medial. And just superior to that, it's a little tough to see here, but there are two menisci, or two mini discs on either side of the knee there, just superior to the tibia itself and distal to the femur. We'll get into more of those. We get into the actual joint chapter next chapter. If you notice too, the patella is only going to articulate again with the femur. It does not articulate with the tibia. Now, other key points here include tibial tuberosity, which you can see as the bump just inferior to the two condyles of the tibia itself. There's going to be a major attachment point for the patellar ligament, as also the quadriceps tendon. You can also see that tibia will have an anterior border crest. There's going to be a very attachment point for the shin muscles, in this case the tibialis anterior, which we'll get into later on. Following further down distally, you're going to find what's known as the medial malleolus. We all have this. This is going to be that bump that you're going to find on the medial portion of your ankle. And of course, your tibia is going to articulate with the talus. You see the domoid portion of the bone there with hyaline cartilage just at the distal end, articulating with the tibia there. If you go more lateral on the anterior view here, you see the fibula. Also going to be attached through a very familiar membrane, the same membrane that's going to use the attachment for the ulnar radius back in the upper extremity, known as the interosseous membrane. This will very simply keep the fibula and the tibia together. Now, the fibula has a head itself, which articulates with the lateral portion of the tibia, and then distally you're going to find the lateral malleolus, which you feel the bump on the lateral portion of your ankle. Very similar, the lateral malleolus tends to hang a little bit lower than the medial malleolus. Looking at the posterior view, again, you can see the condyles of the femur. You can see the intercondylar eminence. This is going to be very important for attachment points for both the anterior and posterior cruciate ligaments. Hopefully, most of you have not injured that in any way, shape, or form is a very tough injury to bounce back from. But here's a nice little shot too of the posterior view of the interosseous membrane as the fibula and tibia will attach themselves together. Strangely enough, it's actually going to be a high ankle sprain that causes tearing of the interosseous membrane, which very simply, if you look at how the talus is oriented, look a little closer in the next couple slides. People that jam the talus tend to spread both the tibia and fibula away from each other and cause a sprain of the interosseous membrane. It's actually a very tough injury to come back from. Now, this slide I pulled from my own lecture. This is not in your textbook, but I do want you to be aware of these types of biomechanical abnormalities. Very simply, when we look at the different joints and also look at different bones, we look to see how they're oriented either in space or whether it be on X-ray or MRI. So very simply, we should see certain types of angles. If you notice in particular at the femur, notice how the femoral neck is angled very differently from the angle of the actual shaft of the femur. So this allows your knee to line up properly over the two menisci on either side of the knee. It also allows the proper weight bearing on the tibia down to the ankle. Now, we see disruptions oftentimes with the knee, especially because it's the biggest joint in the body. It can compensate for all kinds of biomechanical deficiencies. So if you have problems with how well the hip moves or how the pelvis moves, then oftentimes the knee will take some of the punishment. And conversely, too, if the ankles don't move properly, if you have either, say, high arches or dropped arches, this also puts more pressure on the knees as well. So we tend to see this more so in athletes, but you can also see it in just a run-of-the-mill person that walks up and down the street. You see different types of variations. So very simply, the first thing you look at here is the angle between the femur and also we call a plumb line. We're drawing a line between the ASIS as well as the AIS and down through the patella. So very simply, there should be a certain angle within a couple of degrees, usually between 10 to 15 degrees or so, to be normal. Now, oftentimes what we see in what's known as Genu, Varum, where very simply that angle starts to decrease, where it comes closer to zero. So you can kind of see where the shaft of the femur is going to line up almost straight down from the ASIS all the way down to patella. Very simply, we see this more so in men, more so than women, because very simply the acetabulum is going to face a little bit more laterally. It tends to push the femur heads out laterally there as well and rolls the knees outward and also tends to raise up the arches. So as you can see a little bit here on the knees themselves, the medial portion of the knee seems to be rocking on from the femur superiorly down onto the tibia medially and also inferiorly. So it opens up the menisci on the lateral edge of the knees, but also compresses the medial edge of the knees. We see the opposing thing known as Genu Valgum, very simply, or knock knee position. We see it's more so in women because if you have more of an anterior positioning of the acetabulum, tends to roll the hips forward, which turns the knees inward and also drops the ankles there at the same time. So we see the opposing thing happen here, where very simply the lateral meniscus tends to get squished as the lateral portions of the distal head of the femur rocks on top of the proximal portion or the lateral portion of the tibia itself. Now, both these normally can be fixed, and this is something we just do with a lot of physical therapy or chiropractic with, where a lot of times we'll manipulate either the feet if we feel like that's the primary issue, or oftentimes we'll work on the hips there at the same time. But more times than not, even though the knee may be malpositioned, the knee usually is not the issue. It's usually more so compensating for something else. So again, a checklist to determine whether someone has Genu Valgum or Genu Varum. Genu Valgum is going to be more so when the quadricep angle is going to be increased. Don't worry about how to measure the Q angle or the quadriceps angle. Just know that very simply when it's increased, it's Genu Valgum. You're going to find people being in the knock knee position. This is influenced more oftentimes not with either hip position and or deformity or possibly dropped arches in the ankle and the foot. But more oftentimes than not, especially the people that I see that tend to be more on the obese side, where a lot of times the biomechanics of the gait pattern gets thrown off tremendously, and the structure simply cannot bear the weight. So a lot of times I do see the dropped arches first, and person gets more obese as they're not able to walk, or knock knee position, and then eventually some type of hip malformation there as well. For Genu Varum, we tend to see the quadriceps angle or Q angle is going to be decreased. We see people like this tend to be more bow-legged. Oftentimes rickets and osteomalacia, if you remember that from the last couple chapters, can cause this as well. Or we see some patients where they have raised arches in the ankle and the foot, where very soon the foot does not drop properly during a normal gait pattern, and the knees stay more in a lateral or a more of an outward position. While on the subject of Genu Valgum, I want to talk about a very common type of syndrome we see in practice known as the Patellofemoral tracking syndrome. We oftentimes see this in runners, although it's not exclusive to runners. You can see this with other people there as well, or possibly people that play other types of sports. Most of your stop and go sports, we do see this occasionally. But in general, we see this oftentimes with people that are running constantly on a treadmill or running the same routes exactly the same fashion over and over and over again. Very simple, what we see is the patella will start to track laterally out of the trochlear groove. This is going to be the grooves going to be found in between the two femoral condyles. Very simply, what happens is there's an overpowerment of the lateral portion of the quadriceps versus the medial. And oftentimes people have pain that is usually made worse when you walk either up or down steps, sometimes both, but it all depends on the strength of the lateral musculature. In this case, because of the Genu Valgum, a lot of times we see more of a shortening and more of a contraction of the lateral muscles of the quadriceps, as well as the iliotibial band. And then a lot of times that actually creates the Genu Valgum type of syndrome. In practice, we call this more so lateral patellar compression syndrome. Oftentimes you do see this on the lateral side, but it can go medial as well in some very rare instances. And this is relatively fixable. It's a very common type of malady. More of the times we try and work on the medial quadriceps if at all possible. We just do investigate and see how well the feet are moving there as well. If the feet are somewhat flat-footed, then it may also something else that kind of puts more pressure on that lateral portion of the knee itself. But all the times we may use orthotics. We use some kind of balance exercise to help that out as well. But if there also causes more problem on the quadriceps tendon, it can cause the cartilage underneath the patella to soften, and this leads to another kind of problem called chondromalacia patella. So it's one of those things where when we start to lead some pressure off away from certain portions of the tibia and under the patella, then oftentimes you can get softening the cartilage. So it's almost like a reverse Wolff's Law happening on the osseous portion of the bones. Now getting into the rest of the lower limb, as we go distally from the tibia and the fibula, you have next is the tarsus, known as the ankle. The first bone is known as the talus bone. The talus bone is going to be a dome-shaped bone that's going to take all the weight that's going to travel down through the lower extremity to be held onto the talus. It's going to split its weight into the calcaneus, 50% to the calcaneus, also known as the heel, and 50% to the rest of the bones that make up the foot. Now your tarsal bones are going to be analogous to your carpal bones in that you have 7 in this case though. You're going to have the talus, the calcaneus, known as the heel. The navicular is going to be found on the medial portion of the longitudinal arch. 3 cuneiforms, and again going from medial to lateral this time. Medial is going to be the first, followed by the intermediate, and then the lateral is the third, and then the cuboid is going to be most distal and most lateral out of all the tarsal bones here. It's going to be the 3 cuneiforms and a portion of the cuboid that will form what's known as the lateral arch, which I'll show you in a few minutes. Now, as far as the metatarsals, also known as the foot bones, we have 5 metatarsals, just as we have 5 metacarpals. And just like the metacarpals, we number Roman numerals 1 through 5, 5 being the big toe, also known as the hallux, and then 2, 3, 4, 5, 5 being all the way out to the pinky toe. And then, fortunately, the same situation here is going to also have where the phalanges, we're going to have 14 phalanges again, whereas the big toe itself is going to be analogous to the thumb. You have only a proximal and distal phalanx, whereas the other 4 toes are going to have a proximal, middle, and distal phalanx. So you receive both a superior and inferior view of the feet. So again, if we start more so at the talus, you can see the hyaline cartilage lined talus there. You're going to find the calcaneus, which will be just posterior and lateral to the talus, which that particular position will be very important when we get into the actual joints of the foot. That's also going to be partitioned by hyaline cartilage between the talus and the calcaneus. Now, if we look on the medial side first, if we're looking at what's known as the longitudinal arch, this is going to run from the calcaneus all the way out to the distal end of the first metatarsal. So if we work our way from the calcaneus to the talus bone, next is your navicular, followed by your first cuneiform, and then also the first metatarsal, followed by the proximal and distal phalanges of the great toe. The arch I'll show you from a lateral perspective to give you a better idea what this looks like. If you go back to the first or medial cuneiform, you can see going laterally the second or intermediate cuneiform, followed by lateral, or the third, and finally the cuboid, which of course is shaped as a cube. And then just distally, you're going to find metatarsals for 2 through 5, and followed by the 3 individual phalanxes of each toe from 2 through 5 as well, the proximal, middle, and distal. Now, the superior and inferior view is a little bit tough to see how the arches are actually formed. We'll show that to you in the next slide. But very simply, we have two arches that are going to be supported by ligaments and tendons. So this is going to do a couple things for us. One is going to give us the proper foot support for the weight of the body. It's also going to provide leverage while walking, help distribute the body's weight over the foot, which is very important in different phases of gait biomechanics, which I won't get into too much. But very simply, those of you who are taking a very unstable step and trying to test your weight on your foot, it's these particular arches that allow certain types of feedback to go back to the brain in particular portions of the cerebellum, as also the sensory cortex, to give you an idea whether you should put full weight on that particular foot or not. Without these particular arches, it would be very difficult to walk. In fact, we'd all be stuck in almost a baby steppage gait, which very simply they go from flat foot to flat foot. From a locomotion perspective, it's highly inefficient to walk that way. So fortunately, the arches give us more of a streamlined, for the most part, for human biomechanics as far as walking goes. Now, the arches themselves, the longitudinal arch is going to have both a medial, also lateral portion, and also you have a transverse arch. So first, let's look at the lateral arch, since it's facing us first. The lateral arch can be formed by the calcaneus, the cuboid, and also the base or the distal end of the fifth metatarsal. Notice how the arches really do not go into the phalanges. I'll talk about that in a couple seconds here. The medial portion is going to run from the calcaneus through the talus to the navicular to the medial cuneiform to the first metatarsal. And the transverse arch very simply would be all the cuneiforms as well as the cuboid. So all these are very important for forming almost a dome-like position for the foot. So it's very important for both the anterior to posterior positioning as well as the lateral positioning. Most people, when they look at someone walking, they very simply see the foot flexing and extending, but also there's a very particular and very precise motion where your foot has to tilt, both medial and lateral. In this case, we call it supination and pronation, which we'll talk about in the next chapter. You need to have both of these sets of arches working properly to have proper foot mechanics, otherwise things start to break down. And as we know, when things start to break down, they start to hurt, they start to lose their function, and something else has to take over that function in particular. Now, more times than not, as we look at this particular slide here, if you're walking barefoot, you can activate most of the small muscles within the foot and keep these arches somewhat supple. Unfortunately, most of us tend to walk in some form of shoe, which a lot of times will increase the length of the arch, which actually tends to flatten it more so. So people that wear shoes with very little support or have no type of arch support whatsoever, your foot tends to flatten out. And of course, the brain, when we start having repetitive types of motions back and forth, if the brain constantly perceives a flat foot in a flat shoe, it'll keep it as a flat foot, and therefore change all kinds of biomechanics for the foot, up through the ankle, up through the knee, and possibly into the hips, and also to the lower back. And one thing I want to point out as well is what's known as the first ray complex. Now, these are bones of the longitudinal arch, but not all the bones of the longitudinal arch. So the first ray complex is made of the talus bone, the navicular, the medial cuneiform, and also the first metatarsal. Now this smaller portion of the longitudinal arch, the medial longitudinal arch, is very important because it's very integral to proper locomotion. So oftentimes this can be disrupted by either flat feet or high arches. Oftentimes if the feet tend to go flat, it can also cause what's known as Hallux Valgus, or what's known as a bunion, where very simply the big toe or the hallux starts to move more from the normal straightforward position in the anatomical position and starts to actually deviate laterally. So very simply, the first ray complex actually allows a load response on the plantar fascia, which is the covering also the muscle attachments on the bottom of the foot, that allows that to basically connect and actually snap forward to give us that little toe flick of the first toe to allow us to move forward in locomotion. So it's this first ray complex that coils in on itself. It hits a certain point where very simply the tendons and muscles will snap to allow the big toe to load up when it's loading up in the fully extended position, and it'll snap in quick flexion to give us a little push to go forward. So when we basically are learning how to walk, we're learning how to control this. Very simply, the definition for walking, if you look at Webster's dictionary, is the art of putting one foot in front of the other before falling. So this kind of first ray complex is very important, at least in my mind. I think it's very important for you to know because it's very important for locomotion. So again, even though the longitudinal arch may include the calcaneus, the first ray complex will only include the talus, navicular, medial cuneiform, and the first metatarsal. The phalanges are not involved in the longitudinal arch or the first ray complex. they actually move because of the arch and the first rib complex. So here's a nice little shot of Hallux Valgus on the person on the left here. You see the bunion is projecting medially, and you see there's a little deviation or a lateral deviation of the hallux on both the left and right foot. And again, looking at x-rays, anytime we see anything that's radio-opaque, it tends to be more white. If they're more radiolucent, it would be more black. So if you look at the distal ends of the first metatarsal here, first of all, you see a little bit of a shading there, almost oval shape. Those are sesamoid bones there. Those are supposed to be there. These are very similar to the sesamoid bone or the patella found in the kneecap. These are going to be embedded in some of the flexor tendons found on the on the plantar surface of the foot. However, if you look at both the proximal end of the metatarsal, the first metatarsal, and the proximal end of the proximal phalange, you can see that it's going to be very white on those particular edges. It's because you're having more cortical bone thickening there, more calcification, because of Dace's law, you put more pressure on those particular joints, so naturally the body's going to lay down more tissue to protect it. If left gone too long, this can actually cause calcification, so much so that it actually will fuse the joint. And normally I don't talk too much about embryology as far as this course goes, but for the skeletal system, I want you to be aware of a couple different processes here. So for the most part, most skeletal tissue is going to arise from the mesoderm, whereas the skull is going to arise primarily from the ectoderm. Typically, skull bones in particular will develop in one of two ways. The neurocranium is going to form the bones of the skull itself, and it's going to be divided into either the cartilaginous neurocranium, where hyaline cartilage very simply to endochondral ossification, or membranous neurocranium is going to undergo intramembranous ossification. So the bones of the face are going to form what's known as the viscerocranium. This is going to be divided into two parts: the cartilaginous, which will be the cartilage of the pharyngeal arches. This forms the ear bones and the hyoid bone. Whereas the membranous viscerocranium is going to form the pharyngeal arch, undergoes intramembranous ossification and forms the facial bones. So the best way to remember this is actually to look at both the neurocranium and the viscerocranium separately. For the cartilaginous neurocranium, we're looking at the floor of the cranial vault, which includes the occipital, the temporal, sphenoid, and ethmoid bones. As far as the roof, we're looking at the membranous neurocranium, the parietal, and the frontal bones. As far as the facial bones, known as the viscerocranium, very similar, the ones that form from a cartilaginous standpoint include the ear bones, the incus, stapes, and malleus, and only the hyoid bone, which, remember, very simply, the ear bones will be in and of itself only articulate with each other, do not articulate with any other skull bones. Of course, the hyoid bone also does not articulate. It's the only freestanding bone in the skull area. Is going to be suspended within muscles and ligaments for the tongue. So that leaves you with the rest of the facial bones for the membranous viscerocranium, including the vomer, palatine, mandible, maxilla, lacrimal, nasal, zygomatic, and inferior nasal concha. Here we see a nice representation of the field development of the skull. So again, looking at just the neurocranium, so the bones of the cranial vault, looking at the cartilaginous neurocranium is going to be comprised of the occipital bone, the temporal bone, and the sphenoid and ethmoid, whereas the membranous neurocranium will include the parietal bone and the frontal bone. The cartilaginous viscerocranium will include the three ear bones, stapes, incus, and malleus, and as well as the hyoid. And the rest of the bones of the face, while not all shown here, are part of the membranous viscerocranium, including the maxilla, the vomer, the mandible, the nasal bone. A couple others not shown here are going to include the lacrimal bone and the palatine bone. Now, the skeleton of the girdles and extremities is going to be derived from mesoderm. So between weeks 4 and 8 after fertilization, there's quite a bit of growth on the formation of both the upper and the lower limbs. Here you see a 4-week embryo on letter B, showing development of the free limb buds. So you can kind of see the upper and the lower limb bud with just more or less projections more than anything else. By the time you get down to the 6th week embryo, you see the hand and foot plates starting to form. So you can see almost like a little bit of a neck and a head to those particular parts of the upper and lower limb bud. These are known as the hand and foot plates. These are going to be the precursor to the phalanges, the wrist, as well as the phalanges and the ankles of the foot. Now this ties into something we had talked about before, in particular spina bifida, and also different types of hemivertebra, where we were talking about structural scoliosis in the last chapter. So very simply, for vertebra and rib development, you have somites, a left and right. These are going to be cube-shaped masses that form and surround the notochord. So the notochord is going to be the precursor to a few different types of cells, including the vertebral bodies, the rib centers, and also the vertebral arch centers. The notochord also helps along the lines of forming the canal for the spinal cord at the same time. Now, generally, this is where spina bifida starts to develop, at this particular stage, where the vertebral arches oftentimes are not fully formed, or sometimes in the hemivertebra, the vertebral body is not fully formed, or very simply, one of the somites is simply absent, which causes almost a triangular type of position for the vertebral body instead of a full-blown block, to allow the vertebral bodies to stack upon one another to form the vertebral column. The sternum is going to derive itself from the anterior cell wall from the mesoderm. So here we see on the left the 7-week embryo showing development of the arm, forearm, and hand in the upper limb bud, and also the thigh, leg, and foot in the lower limb bud. You start to see the beginnings of the phalanges too in both the hand and also in the foot. By 8 weeks, you start to see more of the ribs start to grow, as well as more endochondral growth in both the upper and lower limb buds. In this case, they're showing in particular the shoulder as well as the beginnings of the elbow. You also see more distinct bending at the elbow and the knee, as well as different partitions of the wrist, also the ankle. Now, even though the phalanges may be there, usually at this stage there's still webbing of skin in between the toes. So as we know with all the systems in the body, each one has its own little role in maintaining homeostasis. So in this case, there's both a direct and indirect way the skeletal system will offer different types of mechanisms to maintain a homeostatic environment. Now, there's only a few things I want you to be concerned with regarding the skeletal system and homeostasis. In particular, know very simply the skeletal system will be a very large, if not the largest reservoir of calcium found in the body. It's going to help maintain a framework to allow the muscles to move the joints. It's also going to offer two different functions as far as the axial skeleton will protect very important portions of the internal organs, in particular the nervous system, brain and spinal cord, also the respiratory system for the lungs, cardiovascular, also for the heart. It's going to offer partial protection to the genitourinary as well as the gastrointestinal. As far as the appendicular skeleton, as we mentioned in the beginning of this particular chapter, very simply it's going to allow the framework to maintain either a certain position or posture, or to allow certain types of movement. So this case came to mind for me when we talk about homeostasis as far as the skeletal system goes. This one is about as far from homeostasis as you can get, at least in an office like mine. Everything here is pretty accurate except for the person's name. Basically, back in November 19th of 2011, I had a patient named Charles. He came in experiencing an injury after working. He had constant severe right lateral ankle symptoms, which are sharp in quality. So we're talking about just around the lateral malleolus, rating to the lateral lower leg to the inferior lateral knee. So remember your terms is going to be just below and to the lateral right of the knee itself. The symptoms were generally worse with standing, movement, walking, and activities of daily living. Those of you who don't know what that is, activities of daily living are what every human does day in, day out. Getting dressed, brushing their teeth, preparing meals, taking showers, cleaning the home. You mentioned that symptoms were overall better with sitting, which doesn't sound too far-fetched. The patient also knew that he had difficulty sleeping due to his pain, as the pressure of the sheet and blanket is enough to cause him discomfort. Now, the patient was roughly 5'5", about 280 pounds, so he was overweight, bordering on obese. He was in marked pain, he was sweating. So he recalled to me that he rolled his right ankle while pulling a tech cart. Come to find out later that actually not only did he roll the ankle, but he rolled the tech cart over the ankle at the same time. So let's talk about what actually wound up happening with this particular gentleman. So in this case, this person was known as a Ewing's sarcoma. What happened was the patient had seen me for roughly 3 or 4 weeks or so with varying degrees of success. We treated him for a couple different types of problems. In some cases he felt better, in other cases the pain came right back, but every time he would have pain while he was trying to sleep. So that didn't really match up with what I thought the problem was. So finally I asked him, I said, look, let's try and get an x-ray. But because it was a work injury, there's certain avenues they have to take, and I won't bore you with tears about how that works in different states. But very simply, you need permission from the doctors who are part of the insurance company that covers that particular work entity to get anything done. So finally, we tried talking to some of the nurse practitioners and talking to some of the panel doctors. They weren't really budging on it. So finally, I said, look, let's just get it done ourselves, and then you pay out of pocket if you need to. And thank goodness we did. So this is not his x-ray. In fact, his particular Ewing's sarcoma is a little further up on the tibia, more so in the upper third of the tibia. This is actually an adolescent Ewing's sarcoma. This gentleman, relatively young guy, if I remember correctly, I don't think I put it down there. I think he was like in his late 20s, give or take. But anyway, it turned out he had what was called a Ewing's sarcoma. So this is a malignant tumor. So those of you who remember we did the skin chapter, We talked about orders of malignancy with different types of skin cancers. This one is one of the more malignant tumors of the skeletal system. In this case, it's usually manifested by what's called a periosteal reaction, which is known as what's called an onion skin deformity. So you look at the black arrows on this particular X-ray. If you're looking at an onion skin, it's very brittle, it's very thin, and it's very layered. So in this case, we're looking at a periosteal reaction. You can obviously understand that he had a very accelerated amount of osteoblastic activity. So remember, osteocytes are going to be the mature bone cells, but on the periosteum, especially if you're going to grow appositionally, then you're going to have the osteoblasts that are going to start creating more tissue. So in this case, this just ran rampant. So very simply, the undifferentiated mesenchymal cells in the medullary cavity in particular, they start to work its way through the cortical bone into the periosteum, and they simply do not stop growing. So in this case, again, he was in his late 20s. So most of the time it happens with males between ages of 10 and 30 years old, although it can be a little bit on the periphery, either older or younger. Painful at night or during exercise because you're putting more pressure on the periosteum. If you remember, we talked periosteum has a lot of nerve endings in it, and has a firm attachment to the bone by the Sharpie's fibers. It is painful. So it got to be so painful that even the weight of a blanket or a sheet on his leg was enough to cause him pain. So unfortunately, I didn't see this person once we had the x-rays done. I got a phone call about from this gentleman about 2 months later, and it was the strangest call I ever got. He called me to thank me that he had his leg amputated. So they actually cut it off a few inches below the knee. So more than 3/4 of his tibia and fibula were amputated, and obviously he hadn't had the ankle or the foot there as well. Basically to stop any potential metastasis of this particular tumor from going somewhere else, whether it be through the bloodstream to, say, possibly different portion of the spine, or possibly other more distinct areas like the lung or even the brain. This, unfortunately, I'm surprised they even waited that long. But again, strangest call I ever got. The guy thanked me to getting his leg amputated because if we hadn't pushed to get the x-ray, this might have gone too long, and it's possible something else could happen. Another cancerous growth could have happened somewhere else. Thankfully, this is the only case I've seen of this. I've had very few cancerous patients in my care, a few here and there, but nothing quite as hard-hitting or traumatic as this one. So let's go through some critical thinking questions as well. In this case, we're going to use our knowledge of the particular types of bones and see whether we can answer these particular questions. So, first one, Mr. Smith's dog Rover dug up a complete set of human bones in the woods near his house. After examining the scene, the local police collected the bones and transported them to the coroner's office for identification. Later, Mr. Smith read a newspaper that the bones belonged to an elderly female. How is this determined? So a few things we can look at. First of all, one of the buzzwords here would be elderly female. So a lot of times, what do we see in elderly female patients? So they could be either osteopenic or osteoporotic. So very simply, there could be decreased bone mass. So that could be one thing that could lead into the elderly female. Now let's also look at other things that we can determine between a female or a male pelvis. So if you remember from the previous slides, a male pelvis tends to be thicker and heavier, whereas a female tends to be a little bit lighter. But also things to look at too, you can look at a wider false pelvis. You can look at the shape of the pelvic brim, where the pelvic brim tends to be more oval in the female, more heart-shaped in the male. You can look at the pubic arch, which could be acute in a male and obtuse in the female, as well as a few other things as well. So if you could also see the obturator foramen, will be different from male to female, as well as the acetabulum, the way it faces. If it's more anterior, then it'll be more of a female, more laterally, more of a male. And there are some other things to look at there too, including the sciatic notches, and also look at the angle of the sacrum, also look at the angle of the coccyx, and also the shape of the sacrum. The sacrum tends to be wider and also a little more shallow. The female, but tends to be longer and a little bit narrower on a male in particular. So more times than not, if they would examine this, they would probably put up against both another male and female pelvis that they have on hand, and very simply we'll compare the two. Critical thinking number 2. A proud dad holds up his 5-month-old baby girl upright on her feet while supporting her under her arms. He states that she can never be a dancer because her feet are too flat. Is this true? Why or why not? Now, this takes a little bit of knowledge, basically about kids in particular, especially infants. If you remember from, I believe, actually last chapter we talked about the different ways we develop different curves in our spine. At 5 months old, generally a baby is not walking at that point. Most of the time they've just learned how to sit up. They're probably rolling over this point, but they're not strong enough to even start to begin to pull themselves up into what's called a cruising position, meaning they're walking while holding on to something, whether it be furniture, whether it be people, what have you. Very simply, not really be able to actually formally form an arch yet by starting to learn how to walk. There's no way to tell whether or not they can tell whether this young lady will be a dancer or not. So this would actually be false because very simply, she's simply not started to walk yet. We don't know what her arches will look like as of yet, although from my own practical experience and also from my professional experience, most kids don't really start to form an arch until about 2 or 3 years old. Especially when they learn how to walk, they have more of a steppage gait, where very simply they lift the foot up and put it down flat, whereas you and I walk more from a heel-toe perspective, which if we don't do this in lab, then we'll probably do this on video for those of you doing things online. Critical thinking number 3. The local newspaper reported that Farmer White caught his hand in a piece of machinery last Tuesday. He lost the lateral 2 fingers of his left hand. His daughter, who's taking high school science, reports that Farmer White has 3 remaining phalanges. Is she correct, or does she need a refresher course in anatomy? Support your answer. So I picked this question because there's a lot of different semantics in here that you have to be very aware of. So first, let's go through here. We know he caught his hand in a piece of machinery last Tuesday. It was his left hand. So again, if we go with if we go with anatomical position, the lateral 2 fingers, if you remember from my previous slide before in the beginning of the chapter, what's considered to be the fingers. In this course, we're going to say the thumb is not a finger. It is definitely a phalange, but it's not a finger. So we're looking at the lateral 2 fingers of the left hand. So again, in anatomical position, the first 2 lateral fingers are going to be the index finger and the middle finger. So fingers 2 and 3. So that's the first thing we have to orient ourselves with. So she mentions that they have 3 remaining phalanges. Now, are phalanges fingers? No. Phalanges are going to be the individual bones in between, in each one of the digits. We have 2 in the thumb, 3 each in the fingers themselves. So if we have 2 in the thumb is still intact for Farmer White, so we have 2 there. We lost 3 out of the index finger, we lost 3 out of the middle finger, so we're 6 down already. So that means we have 3 in the ring and then 3 in the pinky. So technically we have 8 remaining phalanges. So in this case, she is not correct. She needs a refresher course, and that's very simply the answer there. So again, if you orient yourself in the right position, know your terminology. So again, in this particular course, we have 5 digits. The thumb is itself a thumb, and 4 fingers with 5 digits. So the thumb is not a finger in particular. So again, the lateral 2 fingers, including in this case, in this particular question, will be the index and also the middle finger. Lost all 3 phalanges from both fingers there, so we're down 6. 14 minus 6 gives 8 left, and there's your answer. And last question. Critical thinking number 4, why do we have 2 bones in the forearm and 2 bones in the lower leg? And what purpose does it serve to have 2 bones in distal portions of upper and lower limbs? So this case is a little bit more so in the upper extremity versus the lower extremity, but it's very simply we have a 1-2 bone system. We find this in a lot of, actually in all the vertebrates in different degrees. I mean, the bones may be shaped a little bit differently, but we look at certain things, especially when we look into the section of the chicken wings, turkey wings. We'll see if this holds true for chickens as well. But very simply, having the 2 bones on the forearm, and in this case also in the lower leg too. In particular, the forearm, it allows that particular part of the upper extremity to rotate back and forth for more fine-tuned manipulation of the hand as well as the wrist. We do have some rotation on the lower 2 bones of the lower leg, the tibia and the fibula. We'll get into that a little more so. We get into the joints chapter. So there's a little bit of torsion there in the knee, but more so we see this in the upper extremity, again, to allow more fine manipulation for the hand and also for the wrist. So that's why we have the 1-2 bone system in the forearm as well as the lower leg, particularly because we have the capitulum, the humerus, as well as the radial head allows the spin back and forth, allows rotation of the arm, allows rotation of the wrist and the hand. That concludes this particular chapter. We'll do the next chapter, the joint chapter, which I believe is chapter 9. That'll conclude the information for the next exam. So make sure that when you're looking at the particular bones in lab and or Wildly Plus, make sure you know names of the bones, make sure you know all the different landmarks and features of them, and also know what might attach to them at the same time. Good luck, and I'll see you on chapter 9.